Now moving on to our second section, that is the medial epicondyle and medial condyle fractures. In this section, we will be discussing briefly the mechanism of injury and its pathology, especially with the medial epicondyle fractures as well as the medial condyle fractures. And we'll also briefly discussing the medial epicondyle apophysitis, which may be due to the impingement of the pain on the medial epicondyle. Now, medial epicondyle separation is usually, it ossifies as per mnemonic. It's actually at 3 to 5 years of age. At around 5 years, it starts ossifying. It fuses by around 16 years of the time. It's almost the second last to fuse most of the time. And Olecranon fuses at around 18 years, so it's almost second last to fuse. Between these ages, it may be avulsed by severe muscle or ligamentous strain, or it could be due to trauma injury as well. The mechanism of injury in pathology is such that usually the child falls on the outstretched hand. As with the lateral condyle, there was a varus stress on the elbow, which was actually creating a lot of stresses on the lateral side of the elbow joint. In case if it's a valgus stress, it's actually creating a lot of problems with the medial side of the elbow joint, and this results in the wrist is extended and elbow is extended with the elbows rested into the valgus. This results in the medial epicondyle fracture or even medial condyle fracture, or avulsion of the medial epicondyle. An unfused epicondylar apophysis may be avulsed due to tension on wrist flexor. The pain muscles and medial ligaments of the elbow are actually attached, and they may also pull the ligament, this fracture fragment, more, leading to increased displacement. Now, if you see it over here, this is an AP view. If you see, this is this very small fragment which is actually getting displaced over it. But if you see intra-articularly, there is also a fragment which is going in. And when you see the lateral view, this is something which is very important, especially with the case of medial epicondyle. If elbow subluxates, small epiphyseal fragment is dragged into the joint. And we have to be very careful, especially when assessing the joint, because intra-articular bony fragment would lead to disaster. And we have to remove that fragment out of the joint. With the more severe injuries, joint dislocates laterally, and usually the fragment is actually not inside the joint but outside the joint. Now coming to the apophysitis. Apophysitis, it is a painful traction injury of the medial epicondyle apophysis, and usually occurs in young athletes, occurs due to repeated forced valgus movements of the elbow when bowling a ball or throwing. And that can be usually, the pain is mainly characterized over the medial condyle or medial epicondyle, medial side of the elbow, and especially during the valgus stress testing at the elbow, this is where the pain actually increases. The most important thing is it's treated conservatively, usually with rest, and actually NSAIDs and swelling reducing drugs. It subsides gradually conservatively. Now coming to the clinical features. Clinical features could be the pain, swelling and bruising, and it always occurs on the medial side of the elbow. If joint is dislocated, deformity could be obvious as well, and as it's a valgus stress, most likely this will result in a posterior lateral dislocation of the elbow. Sensation and power in the fingers must be checked. Why? Because just behind the medial condyle, there is actually the ulnar nerve which is passing just below it. This could have disrupted the ulnar nerve, and this may eventually let one produce a claw hand deformity. So we have to be on the lookout whether the ulnar nerve, especially the extensor carpi ulnaris, and all these are intact or not. This should be tested and to exclude concomitant ulnar nerve damage, as I just told you. Now coming to the x-rays. Now x-rays are a very tricky part, especially in the case of the medial epicondyle fractures, because if you see it over here in this AP view, you probably would be thinking, but this is the ulna, this is capitulum, but if you see it, what is this shadow which is intra-articularly happening? Although this looks like a capitulum and this looks like there is nothing actually wrong with this x-ray, but if you see the lateral view, can you appreciate intra-articular fracture fragments which is present inside the joint? That is why it's very important, especially in the case of medial epicondyle. It's very common to miss this injury. Why? Because most of it is cartilaginous. It hasn't actually fused, especially in the case of children which are way below. Let's suppose a child comes to you of 3 years of age. Now the medial epicondyle starts fusing at 5, so probably you not see this kind of situation. So it has to be very important to rule out all these kind of problems, because it carefully assess these children. Medial epicondyle apophysis is displaced, distally rotated. It has to be, and we have to check that if the joint is dislocated or not, and fragment if lies distal to the lower humerus or not. The important point is sometimes you have to get the x-rays of the other elbow as well, just to make sure that this you don't miss it, especially in the case of children. Coming to the treatment, minor displacement is actually disregarded, but if it is extra-articular fracture, elbow can be mobilized. If epicondyle is trapped inside the joint, it's an intra-articular element. It must be freed. You have to take out intra-articular fragment out of the joint by either OREF or by taking it, maneuvering it in a close reduction method, so it comes out, and then you can fix it by close reduction and tunnel fixation. Manipulation with elbow in the valgus is done. Wrist is hyperextended. A joint must be opened if after even the manipulation the fragment remains inside the joint, and if fragments retrieved and fixed back in the position, it should be done by open reduction tunnel fixation if it's intra-articular and still remains intra-articular despite manipulation. Displaced fractures, if they are not trapped into the joint, do not need to be operated on. Usually valgus instability or marked displacement, for that we need open reduction tunnel fixation. Otherwise we can go for close reduction tunnel fixation of these minimally or displaced fractures. Screws usually not done, especially in the case of children, but can be done in the case of adults. Now coming to the complications of medial epicondyle fractures, these include ulnar nerve damage, which is usually associated with the trauma, mild symptoms, and there may be associated neuropraxia, which may settle down in 2 to 3 months time. Late is actually the stiffness, especially the elbow stiffness, which is often limited for months. And why? Because sometimes you have to keep the elbow immobilized after even open reduction fixation for 6 to 8 weeks, so it takes sometimes a lot of time at times. Now coming to the fractures of medial condyle. It is less common than either the fracture of the lateral or even the separation of medial epicondyle apophysis. But this can also be a possibility if a child is around 7-8 years old. By the time medial condyle ossification centers would have appeared, something would have ossified, and what you see is this kind of a fragment in which you can appreciate this is actually a medial epicondyle fracture. But if you see it on the lateral view, you probably would remember it's not an intra-articular, but it could be extra-articular fracture as well. Usually the commonest mechanism is always caused by the fall from the height, and that is on the outstretched hand involving drag blows of the elbow, which is very rare, but it can happen as well. Usually are landing on the outstretched hand with the elbow forced into valgus. Now this is something which is a very common scenario for especially all the medial side injuries, and fracture line could run through the physis, exiting in the trochlear notch or even further laterally, or medial fragment may be displaced most of the time. So there is also Milch classification for this as well, which also divides it into whether it's involving the metaphysis, physis, and epiphysis or not, into different types as well. Now coming to the clinical features and x-rays, intra-articular fracture usually results in a pain or swelling. In older children, metaphyseal component may be seen on the x-ray actually. We would denote a Salter-Harris type 2 injury. In younger children, much of the medial epicondyle apophysis is cartilaginous, so it may not be very much visible on the x-ray, but even on x-ray it appears a very small fragment. But when you open it up, you see a very large fragment because of cartilaginous may not be seen on the x-ray. Full extent of the fracture may not be recognized, and seeing only the epicondylar ossification center may mislead the surgeon. That is why it's very important to carefully analyze these fractures, especially the lateral condyle and the medial condyle, because ossification centers have not completely appeared, or even the ossification has started but they have not completely ossified. So the cartilaginous spot won't show on the x-ray, and we may have to go for an MRI to assess how much fragment actually is present or how large the fragment is. And if it's doubtful, the first and foremost is to get the normal limb. If suppose a child comes with a problem in the right elbow, just get an x-ray of the left elbow, AP and lateral view, just for the comparison, so that along with the clinical history and examination you can assess both the x-rays. Coming to the treatment, undisplaced fracture are treated by splintage. X-rays are repeated until fracture is healed to ensure that it does not become displaced. In displaced fracture, we have to treat by either close reduction or open reduction. Initial manipulations done to see a smooth KYs or past closed reduction internal fixation can be done. If it remains displaced or rotated, we can go for open reduction internal fixation and fixation with the smooth panes. Post-operative management is similar to that of the lateral condyle, and usually the post-operative management includes that we keep it in the slab for 3 weeks and remove the KYs at 3 weeks, and then we continue this slab for at least three more weeks. So the total post-operative immobilization for elbow is around 3 to 6 weeks, and after 6 weeks we can remove the slab and start a gradual range of motion. But by the time the elbow is immobilized, we can still ask the children to actually do the wrist and hand exercises and shoulder exercises as much as they can. Now coming to the complication includes lateral dislocation of the elbow, because it's usually valgus stress is there. It may be associated with a fracture. There could be ulnar damage. Our late actually include the stiffness of elbow, which is why, because usually sometimes even 6 to 8 weeks may be required to keep the elbow immobilized. And when the elbow is immobilized for such a long time, this may result in some degree of immobilization or even stiffness at the elbow joint. In this section, we have briefly covered the medial epicondyle fractures as well as the medial condyle fractures. And the important point is that a Milch classification for both of them, it usually ossifies at around 5 years of age, and actually complete ossification results at around 16 years of age. The important point is that whenever the child comes with a medial epicondyle or a condyle fracture or even medial epicondyle apophysitis, we need to carefully analyze with the history and examination. Sometimes we have to go for X-ray of the other elbow as well, which appears to be normal. Even still, sometimes we may need to go for an MRI to assess the degree of the fracture, which is most of the time undisplaced fractures are treated conservatively, while displaced fractures can be treated by either closed reduction internal fixation or open reduction internal fixation with smooth percutaneous pinning. Thank you very much. Keep watching sqadia.com.